Good morning from the West Coast and UCLA, which as a land-grant institution, we pay tribute to the Tavanga peoples as the traditional caretakers of the Los Angeles Basin and the South Channel Islands. Welcome to today's presentation from the National Network of Health Surveys. Please, as we go through today's workshop, we want this to be as interactive as possible. Please use the chat for questions, general comments, and discussion amongst yourselves. But if you have a question for today's presenter, please use the Q&A function. That is where we will be looking for questions to pose when we get to the Q&A section at the end of his presentation. This is a product of the National Network of Health Surveys, and our mission is to try to develop data from surveys and other health data sources that is high quality, are designed and useful for informing policy and programs at local, state, and national levels, and that collect data that are comparable so that we can look across sources and across jurisdictions and be able to compare data that is collected in many different places. This is a voluntary group, and we have everyone from data producers to data users who all just want to make sure that at the end of the day, the health data that they are using is high quality. And we invite you to join our network if you're interested in topics such as today's. We are presenting these workshops as a way to help all sorts of data users, whether or not you are a survey or otherwise, to improve the collection, processing, and reporting of increasingly disaggregated racial and ethnic data. This data is so important to help address health disparities and improve health equity. So we're trying to address any of the barriers that one might encounter in seeking to get more granular with your race and ethnicity data. This is supported by the Robert Wood Johnson Foundation, and under this grant, we are presenting these technical workshops and offering technical assistance. If you have some specific needs and want to reach out to us, we'd appreciate hearing from you. Today's workshop, we have Marc Elliott from RAND. He is a senior principal researcher there and also their distinguished chair in statistics. He was also recognized in 2014 by Thomson Reuters as one of the top 1% cited scientists between 2002 and 2012. We are very lucky to have him here today to work through a very important part of working with data to help improve that disaggregation, and that is imputation. So I'm going to turn it over to Marc now.
Thanks very much, and let me see if I can get the screen sharing working here. Appreciate the opportunity to talk to you today. Is that displaying properly?
Yes, it is.
Terrific. So thank you again for the opportunity to talk to you about some of this work. This is work that was motivated by the desire to measure and address health inequities when there isn't self-reported data in a complete form, or when there's an administrative form of data that's imperfect. So here's an outline of what I hope to talk about today. First of all, why you might want to do this in the first place. Secondly, I'll talk about a couple of the related methods that we've developed in this area. One more general, one more focused on Medicare data. I'll give examples of a number of applications that we've done, I think mainly just to kind of provide examples of ways these sorts of things could be used. I'll talk about some concerns that have been raised about the concept of doing this and some thoughts on those concerns. I'll also talk about sort of specific ways that these kinds of things could be used if you're interested, and also some ideas of future directions, things that we're not yet able to do, but think we see a path forward to doing, and in some cases, if you're interested, you all may be in a position to help make some of those future directions possible. I'm sorry, I'm having a small bit of trouble here. One moment. Let's see how this. Sorry, I have a brand new computer as of 2 days ago, and I'm of course running into a small technical issue here, but I think I can. Let me see if this works. So the thing which motivates this work is that race ethnicity data are essential for monitoring quality, coverage, costs, and access. The collection of this information was mandated by the Affordable Care Act. One of the things I want to emphasize from the start, and you'll probably hear me repeat this, is that in all instances, we view a person's self-reported race and ethnicity as being the gold standard. And so in any instance where that's obtainable, that's what we want. And in particular, we want self-reported race and ethnicity where somebody gets a full and modern set of response options. But in a lot of important applications, you don't have access to that for everybody in a data set. Sometimes you only have administrative information. Some of that administrative information can be imperfect in various ways. There are administrative data sources that involve third-party report where somebody was assigned to a category based on somebody else's impression of their appearance. You could have situations where somebody was allowed to self-report, but with a very constrained set of response options that didn't allow them to self-report as they prefer to. And when you do have proper self-reported data sets, they often have fairly high rates of missingness, and that missingness is often not random. For example, the current marketplace data have about 70% self-reported race and ethnicity, but about 30% missing, and that missing is non-random. A lot of commercial health plans, for example, have tried to collect data on their members, and often you see really high rates of missingness. And if you have missing, inaccurate, unrepresentative data, then that really can be a barrier to trying to measure any of the many things that are really important in healthcare and that may vary by race and ethnicity. So as many of you will know, there was a time when it was considered inappropriate to collect self-reported race and ethnicity data because there was a concern that if it wasn't being used for a legitimate purpose, that it might be used to discriminate. And so even when it became more commonplace to think about collecting race and ethnicity data for the purpose of measuring and addressing inequities, it's been a sort of a slow process in many cases in doing that. There are various ideas that people have about ways to collect this in a complete manner, at enrollment, at a point of service, via a survey, and often, as in all sorts of means of data collection, the people from whom you obtain this information are not necessarily representative of the whole group. And so the way that we see everything I'm describing today is fitting into this is something that supplements and complements this gold standard of self-report. And as you know, and the self-report, is the ultimate goal. But this is something, that in many cases can allow you to fill in some gaps and learn things as those gold standard data accumulate. So a lot of what I describe is based on information that relates to names and residential addresses. And there are sort of two reasons why those sorts of things can be helpful. One is that they're widely available in all sorts of health and other administrative records. And then secondly, together, they contain a lot of information that allows you to make inferences about race and ethnicity at a group level. And I'll also turn to that point several times in what follows. And the goal is to try to make inferences either starting from scratch or building on administrative data that, as well as possible, align with what people do self-report when they're asked and they're allowed to do so with the full set of choices. And in what follows, I'll describe sort of a general method and a more specific method tailored for Medicare data. And I talk about the Medicare example, not just for inherent interest in Medicare data, if you have it, but also as an example of how the general approach can be customized to a particular population and a particular set of data fields, if that's of interest. And then the last sort of bullet on the slide, I'd really like to emphasize from the start that if sort of my number one sort of view here is that self-report is the gold standard. My number two view here would be that these are not tools for making decisions about individual people, and that really one shouldn't act on this information at the personal level unless you have an actual self-report to back that up. But when used in comparing groups, I think there's a lot of value in using this information. So just to describe some of the methods that are out there, there's the Bayesian Improved Surname and Geocoding Approach, or BISG, which uses surnames and residential address. There's a related version that we're currently calling the modified BIFSG. F is for first names. That's a slightly higher performing version that incorporates first name as well as last name. I see there's a typo. It says adds surname information, but it should say adds first name information. And then the Medicare BISG, or MBISG with M for Medicare, is a specialized version that takes advantage both of some data elements that are unique to the Medicare context, but also tailors a bit to the characteristics of that population. So a little bit more about the general approach, the BISG. So this is based on several products that the Census Bureau puts out, and one of them is a more general product, which has been out forever, which is just the linkage of residential address to race and ethnicity. And we use that information at the block group level, which is the finest grain level at which it's publicly available. And then there's a second product that was developed, which is based on surnames. And this was first put out in after the 2000 decennial census, and then a second version was put out after the 2010 census. We hope that another version will be coming out corresponding to the 2020 census, and in particular are requesting sort of a more detailed version of this. But briefly, the way it works is this. Anybody whose surname is shared with 100 or more people, and that's about 150,000 different surnames, has an entry in a publicly available table. So you could look up your surname, and then you could see the counts of people in 6 different racial and ethnic groups who have that surname. And I'll talk about those groups briefly in just a moment. About 90% of everybody has a surname that's on that list. The people who don't have surnames on that list often have compound surnames or have rare surnames, and there are things that we can do to take advantage of that. It's informative if you're not on the list as well. So, for example, if your surname is shared with fewer than 100 people in the U.S., you're more likely to identify as Asian than if you are on the list, for example. So there are things you can do with that as well. The 6 categories that we use in the BISG were essentially dictated by the structure of the surname list, and so the way that everything is set up is there's a category which corresponds to everyone who indicates Hispanic ethnicity, irrespective of what they said with respect to any of the race categories. There's a category that corresponds to anyone who didn't indicate Hispanic ethnicity but endorsed more than one race, and that's the multiracial category. And then there are 4 other categories that correspond to non-Hispanic endorsement of just one race, and so that would be white, Black, American Indian, Alaska Native, Asian and Pacific Islander. The one complication that category of Asian and Pacific Islander is actually people who indicate Asian or Pacific Islander or both. And so one way to think about this is that what the algorithm is trying to do, based on the way that Census set this up, is it's trying to match self-report when you use sort of a 2-item ethnicity and check all that apply race item, and classify people in that way. So, one thing that may occur to you is that this particular 6-category approach might not be what you would ideally want to do. We feel the same way. We're hoping to be able to get products from Census that allow us to do this in a more granular way, and in a way that allows us to examine, to drill into the multiracial category into different configurations, because otherwise it's very, very heterogeneous, to look at intersections of Hispanic ethnicity and different racial identifications, and to look within some of the categories like Hispanic ethnicity and Asian race into some of the finer grained groups, for example. We think all this should be technically possible, and are hoping to prevail on Census to make those kinds of things possible in the future as a preview of some of what we're hoping to do. But the idea here is that with BISG, with any data set where you have name and address information, you can generate a set of probabilities that each person belongs to one of these 6 different groups. So the next thing that I would note is some approaches that are out there that involve trying to impute people's race and ethnicity don't use probabilities as an end product, and instead make a best guess and sort of hard classify somebody into a category. We don't do that for a variety of reasons. One of them is statistical, and another is philosophical or conceptual. So from a statistical point of view, if you take those probabilities and you just say convert everybody, sort of assign somebody to the category with the highest probability, that will bias your results. In particular, it tends to result in undercounting small groups, but it also creates measurement error. And so you're better off using the probabilities directly, and it turns out that's not too hard to do. And if you're interested in why that's the case, there's a article mentioned here that appears at the end that describes why that's the case. But then the other thing is to us conceptually, to assign somebody a category sort of blurs the distinction between self-reported and imputed data. And for me, at least, having these probabilities is sort of a direct recognition of the uncertainty that's there for each person. And for me, it's like a string tied to my finger reminding me that this is not what somebody said. This is an imputation that you use to make group level comparisons. Let's see. So a little bit more on this. Well, maybe I'll in the interest of time, move this forward a little bit. The other thing that I'd like to sort of say more generally about this is that sometimes people imagine that the use of these indirect data might be an either or situation. So I know from self-report the race and ethnicity of 30% of the members of my health plan. So, what do I do? And the general guidance is that you can actually use self-report where you have it, and you can use the imputed data where you don't. And things are set up in a way where they're compatible with one another. And the easiest way to do it is to actually treat self-report as having a probability of 1 of being whatever you self-report and a probability of 0 being everything else. This is just an illustration of what these surname lists look like. So here are the 10 most common surnames in the US as of the 2010 census, and you can see there's really different distributions depending upon your surname. So if your surname is Smith, there's a 73% chance based on that information alone that you identify as white. There's a 22% chance that you identify as Black. In contrast, if your surname is Williams, there's a 49% chance that you identify as white, 47% chance that you identify as Black. If your surname is Garcia, there's a 91% chance that you identify as Hispanic, and so on. So there's a lot of information here. And again, crucially, where some early work just had on-off surname lists. And so so early work might have just said, if your surname is Rodriguez, then you're Hispanic. What this approach does is it takes these particular probabilities, because, for example, there's a distinction between the information in Garcia and the information in Rodriguez, and then it uses that along with other bits of information. So this is just an illustration of what it would look like to use the residential address information. So you geocode that down to the census block group, and then you look at the distribution of race and ethnicity at that block group in order to develop probabilities. And we use Bayes' theorem to do just a combination of the information based on surname and the information based on residential block group to get a set of probabilities. So a hypothetical person who had a particular surname and lived in a particular block group might get a set of probabilities like those that are at the bottom of this slide. And you'll note that these probabilities add up to 1 because they're defined here as mutually exclusive categories. And so this person's highest probability is of being Black, 68% chance. And that means, but that doesn't mean that this person gets treated as Black. It means that their data will contribute more to estimates of the health and healthcare of Black people than of white people. But a group level inference is built up based on all these probabilities from all these people. Here are a couple slides. The slides will become available later, so I'll maybe not spend as much time on some of these, but just to illustrate in the next slides, you might have somebody's name, their address. This is a John Lee who lives in a particular place, in a particular zip code in Alabama. You would run these things against the surname and address information, and you get something out of that. I'll now introduce the Medicare version of this, and this was originally motivated by a desire on the part of CMS's Office of Minority Health to be able to compare the clinical quality of care by race and ethnicity, and they wanted to do this using the HEDIS data set, and the HEDIS data set is linkable to administrative files for Medicare beneficiaries, but it doesn't contain any self-reported information about race and ethnicity. Their original administrative race ethnicity variable was based on information that was conveyed by the Social Security Administration. And when that was filled in was essentially based on when you last registered or updated information with the SSA. And for Medicare beneficiaries, even now, many of them registered prior to 1980. And if you did so prior to 1980, your only options for identifying your race and ethnicity were to designate yourself as Black, white, or other. And that resulted in an administrative variable that was really good at distinguishing people who identified as Black from those who didn't, but otherwise was really quite poor, and in particular tended to misclassify a lot of people who identified as API or Hispanic as white or other, which was a sort of a hard category to interpret. So we developed a Medicare specific algorithm that uses name, address, this SSA-based variable, and a bunch of other things in order to be able to develop a set of probabilities for Medicare beneficiaries. And we use these in turn to measure national levels of performance for these clinical quality measures by race and ethnicity. And also we drill it down within specific Medicare plans. And if you're interested in seeing some of these data files or some of the reports that have been generated from them, there's a link here that takes you to that portion of CMS's website. Just to help you sort of visualize what what was going on before, one of the ways that we can validate and establish the issues with the original data element is by linking it to what people self-report on a survey. And so, for example, of the people who self-reported being Hispanic, if you look at the third row, 58% are misclassified as being non-Hispanic whites. Only 30% are actually listed as Hispanic. Of people who self-reported being Asian or Pacific Islander, only about half were listed that way in the variable. 35% were listed in the other category, which is sort of difficult to use. And so you see there's really not a great original variable. So briefly, what this variable does is it primarily takes three data sources: name, address, and information from this original SSA variables. It takes a few other, brings in a few other elements, and it generates a set of probabilities that really improve on the original variable. Just a little bit on the way of a slide on methods for how we sort of validate the performance on this. What we do is we have data from about 300,000 people who responded to the CAP survey, and so that's our gold standard source of self-report. The survey has non-response, but since the sample frame is this incredibly rich administrative data file, we're able to do really detailed weighting to make the respondents to this data set representative of the whole. We look at the concordance between these probabilities and self-reported data in order to assess how accurate the predictions are. And we also, so that we don't overfit, we do everything with what's called a 10-fold cross-validation, which means that we're not using the same data to fit the models as to evaluate the models. So here's an illustration of the concordant statistic, which is sometimes called the area under the curve, with the original variable and the current variable. If you're not familiar with this metric, it's set up on a scale where 0.5 represents chance performance and 1 represents perfect prediction. And the usual heuristics are that 0.9 is excellent, 0.8 is good, 0.7 is sort of the threshold of acceptable. And so if you look at the blue bars from the original variable, you see that the original variable had excellent correspondence with self-report for whether somebody identified as Black or not, but only good for white or not, only in the acceptable range for API or not, and not even that for Hispanic or not. With a method, all of those concordances fall into the 0.96 to 0.995 range, and so it's much more accurate than in the apps than just using the original variable. Here is sort of a summary of 3 of the methods that are out there. It's a little bit of a tells you about the performance level, and also tells you about what the goes into these. So the simplest model, the one that uses just surname and address, is what we call the BISG, and the concordances there run in the 92 to 98% range for the 4 largest groups. So that would be Asian Pacific Islander, Black, Hispanic, and white. But its performance is just not good enough to recommend for inferences, even at the group level, for American Indian, Alaska Native, and multiracial groups. And so it produces those estimates so that those estimates don't get pulled in with the other 4 groups. But you know, we're not as confident in those. When you start throwing in first name as well, so what sometimes gets called the modified BIFSG, then that brings up the performance sum. So the 4 largest groups are in the 95 to 98% range. The American Indian and Alaska Native starts to just get into the good range, so that we think that some cautious use of that is okay. For the multiracial group, you're still not even at the acceptable threshold. So we still sort of don't recommend that those inferences. The MBISG is now kind of, you can see, a little bit higher still for the 4 largest groups, and it's pulling in a variety of information. It's now getting the performance for the American Indian Alaska Native group is now starting to get more solidly into the good but not excellent range. The multiracial performance is just starting to get into the acceptable range, but we think that's still, we're sort of queasy about this when the concordance doesn't hit at least 80% ourselves. Let me pause here, and I'm gonna sort of describe just some examples of the different applications, some of the different applications that we've used. But maybe before I do, could pause to see if there's some questions or clarifications about the sort of initial setup before I continue.
If you want to take some questions now, that would be great. The first question is, how does BISG control for gender and marital status? Does it use maiden name for women?
So that's a really good question. One of the things that we were interested in from the start was, is it as accurate for women as for men? And the basic BISG, which uses surname only, tends to be a little bit more accurate for men than women among people who identify as API, Hispanic, or white, and slightly more accurate for women than men among people who identify as Black. And it's more common for women than men to change their surname at marriage, and that's likely the source of some of this. One of the ways this plays out is suppose that your original surname was Garcia, but then after marriage it became Jones. And suppose you live in an area, and let's say that you identify as Hispanic, and let's say you identify in an area, you live in an area where there's a relatively high proportion of Hispanic residents, and now your surname is Jones. Then in that case, you'll see sort of less. You'll see probabilities that are sort of much more ambiguous in that case, that reflect some of the uncertainty because different parts of information say different things. One of the reasons why the second and third algorithms work a little bit better is they bring in first name information, and it's often the case that your first name can provide some additional information that disambiguates last name information. So for example, Mary Jones and Maria Jones convey different information, and often that in combination with the residential address information goes a long way. But the main thing I would say is that this is a good illustration of why this is a tool for group level inference and individual level, rather than individual level inference. So somebody whose surname is one where their own race and ethnicity has a low probability, that essentially that person their data is used more cautiously in group level inferences, and it's done in a way that results in really accurate group level inferences. But it's a good example of why you wouldn't actually try to say what somebody's race ethnicity is based on these probabilities at the person level, while you really just do while you do that sort of only at the group level. And in the group level way, it essentially works really well because the accuracy, especially when you have first name in there, is pretty good. It's not, once you throw first name in there, the accuracy is similar for men and for women, and the group level accuracy is really good. Maybe another question now, and then I'll kind of turn to the applications and leave plenty of time for discussion at the end.
Certainly. Actually, the question that just got added was, can you please go over the concordance interpretation once again for more clarity?
Sure. So I'll give a technical definition of that, and sort of and also sort of intuition as best I can. So this is a statistic it's sometimes used in logistic regression, in the same way that R-square is used in linear regression. And here's a technical definition. Let's say you take a random pair of people in your data set, and I'll use Black as an example. You take a random pair of people in your data set, one of whom identifies as Black and one who does not identify as Black. The C statistic then asks, how often for those random pairs of people does the person who really is Black have a higher predicted probability of being Black than the person who isn't Black. And so that's why 50% or 0.5 represents chance, because if your predictions were no good, then the chance that the person with a higher probability of being Black really was Black would be 50-50. On the other hand, if your predictions are perfect, then it would always be the case that the person with a higher probability in any random pair of people, one of whom was Black, one of whom wasn't, the probability would always be higher for the person who was Black. And so this gives you sort of a continuum where 0.5 is chance and 1 is perfect performance. If you're familiar with the sensitivity and specificity curve, what's sometimes called an ROC plot, then the C statistic also corresponds to the area under that curve. And when sensitivity and specificity hit 1, both hit 1, then the area under the curve is 1, so this relates to that as well. And the last thing I guess I would say here briefly on the concordant statistic is, one of the nice things about it is you can use it with either categorical or probability variable, and so it's a measure of performance that works well when you don't want to turn predictions into categories, and it allows you to use the probabilities directly.
Through Chicago, they're going through Denver.
Somebody may be unmuted.
Please mute your phones.
Let me sort of talk through a few applications to give examples of this. We've used this, as I alluded to before, to make national and contract-specific stratified reports of performance by race and ethnicity. We used it to develop a health equity summary score in order to incentivize excellent care to at-risk groups. We've used it to be able to measure racial and ethnic differences in the rates at which people voluntarily disenroll from Medicare plans. We were interested in whether the people who did and didn't self-report race ethnicity differed by race and ethnicity, and we were able to use it to look at that. We were interested in estimating the enrollment by race and ethnicity in marketplace plans. We were interested specifically in inequities in behavioral health quality measures, and we're interested in trying to detect and correct bias in clinical decision algorithms or pay-for-performance schemes, and also we're often interested in linking this to GIS mapping for visualization. I'll go quickly to leave time for discussion. These measures have been used in a variety of settings. Just some examples of what you can do. Suppose you want to just estimate a population size, such as the percentage of plan enrollees who fall into different racial and ethnic groups. What you can do with these probabilities is you can sum them to get estimates of population sizes. You can average them to get estimates of population percentages. Suppose you want to do a stratified measurement. So you want to estimate the percentage of Hispanic beneficiaries in your plan who receive colorectal cancer screening. Then you can calculate a weighted average using those probabilities as weights. Often you're interested in making comparisons between racial and ethnic groups, either with or without sort of other factors as adjusters. You can do that in the context of a regression model, there's several ways to do that. There's an approximation that involves directly plugging those probabilities in and interpreting them as if they were indicators. That is that's an approximation, and whether that's how good of an approximation it is, sort of depends on the circumstances. Often it's really pretty good. There's a sort of a better approach that involves things like proc-MI analyze for people who are familiar with that, but I won't go into those details now. This has been used in things like the construction of all payer claims databases, where you wanted to add a field on race ethnicity where that wasn't present. This application one, which I'll sort of skip past now, is one of the ones that I've been talking about a little bit already, which is some of what we do for CMS currently. In application two, there's a health equity summary score that we developed, and one of the key elements of this was how well a Medicare plan did for not just overall, but for specific groups of beneficiaries, low-income beneficiaries who are dually eligible for Medicaid, as well as API, Black and Hispanic beneficiaries. And the MBISG was essentially the tool that allows us to look at the racial and ethnic aspects of that. In this example, we were interested. So voluntary disenrollment from a Medicare plan means you left it for some reason other than the plan shut down or you moved out of its coverage area. And we were able to determine that, for example, Hispanic and Black Medicare beneficiaries in particular disenrolled at substantially higher rates than non-Hispanic white beneficiaries, which could indicate that either there were greater changes in the circumstances of those Medicare beneficiaries, health or financial or otherwise. It could indicate that the properties of those plans aren't being communicated as clearly. In any case, this sort of gave us some insight into the fact that these voluntary disenrollments were not happening at similar rates. There's a survey that asks Medicare beneficiaries to report their race and ethnicity at the very end of the survey. Almost everybody does, and all but about 4 or 5% of people do. And we were wondering if that was a random 4 or 5% or not. And we found, as you can see in this first column, that it did vary somewhat. And all but about 3% of white beneficiaries, but all but say closer to 7% of Black beneficiaries self-reported their race ethnicity. And then, although I won't go into it here, although there's more on this in a paper if you're interested, we then tried to figure out to what extent that was just people not getting to the end of the survey and therefore sort of missing the demographic section, and that was 1 or 2% of people, and to what extent it was people sort of specifically skipping around the race ethnicity question, and you can kind of see how that breaks down. And so some in that last column, in particular, Black beneficiaries were a little bit more likely to specifically skip that item rather than it being a function of sort of overall item non-response. I'll sort of glide past this slide about estimating the composition of the marketplace population. There's a paper in Health Affairs. We were interested in looking at inequities in behavioral healthcare quality measures. This is one where we thought there might be really big differences in the same plans, and in fact there were. This is looking at sort of overall disparities relative to non-Hispanic white beneficiaries. These are huge differences. The axis is a plan level standard deviation. You can see on some of these antidepressant Medicare medicine management measures, you're seeing differences of more than the whole plan level standard deviation affecting multiple groups. And unlike a lot of these measures, these are mainly differences within the same plan. A lot of other health measures, you're mainly seeing differences driven by who's in the better and worse plans, but here you're seeing really big differences in many cases, even within the same plan. Briefly, there's a lot of interest in detecting bias in clinical decision algorithms. This can sort of show up in a lot of ways. You can have bias because race and ethnicity might be measured and explicitly used in a way that's inequitable. You could have ways in which that's not the intention, but something which is effectively a proxy for race ethnicity is guiding a decision in a way that has an inequitable effect. And a lot of times the way some of this happens is you have a model that essentially tries to model current practice and treats it as if that were appropriate practice. And if that's the case, then any patterns that are currently inequitable will be confused and treated as reflecting actual need. And we've started to do some work that essentially uses BISG to detect whether the effect of a decision rule actually does vary by race and ethnicity, even if there wasn't an intention to use it. And if so, we're developing approaches to essentially take out the association with race ethnicity, either in an early stage or a late stage. Similarly, you can, one of the big challenges with a lot of pay-for-performance schemes is if some racial and ethnic groups are more likely to be receiving care from worse doctors, worse hospitals, worse health plans, then any pay-for-performance scheme that links payments to quality can move resources away from people who care for often Black and Hispanic patients in particular. And in combination with some work that Cheryl Damberg and I did before, we're looking at ways to essentially take any pay-for-performance scheme as a starting point and then using BISG, where self-reported race ethnicity doesn't exist, to alter it in a way that guarantees that dollars per patient awarded don't vary by race and ethnicity, but it's still the case that the payments go up with performance. You can also sort of link this data to GIS coding so you can visualize patterns. And I'm gonna skip ahead and talk about some of the concerns that have been raised and some of the ways that we've tried to address those. And then also I'll just talk briefly about next steps. There's some, in the context of the Medicare version, there's been some concern about, there sometimes have been sort of a belief that this was, that this largely constitutes making imputations where people have deliberately chosen to not report their race and ethnicity. And in the case of the Medicare data, this isn't the case. It's mainly, what it's mainly doing in practice is trying to better match self-report where people weren't allowed a full set of response options. And it's also the case that, at least in the Medicare context, when you do ask beneficiaries to self-report their race and ethnicity, they do so about 96% of the time. There's been, in some cases, people have been more comfortable with geographic-based analyses than with something that uses other data elements. And so we did examine kind of what you could do with geography alone. If you're trying to use geography as a way of getting at race and ethnicity, then for at least the four largest groups, you're looking at generally 2 to 3 times as much error variance when you limit yourself to the geographic information than when you bring in some of these other data elements as well. The other thing that's a little bit challenging about sort of a geographic only approach is that implicitly it assumes that there aren't racial and ethnic inequities within a geographic area. And that's something that's unfortunately demonstrably false. And the last thing I think I would sort of say sort of in this brief section is sometimes there's sort of a general discomfort with the idea of imputation for race and ethnicity sort of on principle. I thought that a recent article in the New York Times about how this is done at the Census Bureau was helpful, at least to me, in sort of thinking about this, because as many of you will be aware, the Census Bureau does direct estimation and enumeration wherever possible, but there's longstanding evidence that if you stop there, you would get systematic and biased undercounting of some groups rather than others. In particular, you would tend to undercount Black and Hispanic people in the United States, and that if you were limited to direct enumeration, that there would be inequitable allocation of resources, representation, and so on. And that, and so in many ways, this is sort of a longstanding precedent for using directly reported and directly enumerated data where it's available, but also recognizing that data sets that have missing information are often unrepresentative in ways that could have inequitable consequences. And in a lot of ways, if I'm sure everybody here has read a lot of the interesting information and analyses that are coming out of the 2020 census. And one of the reasons that we're able to see a lot of this, is because of the use of these kinds of methods. So as of about a week ago, we put up a website describing the BISG. We distribute code for that. If you're interested in using it, we're in the process of updating that. For the Medicare data, we don't distribute the code on that right now, but the actual probabilities are available through the CCW, if that's of interest. Lastly, I've alluded to some of these before, but we would like to have better performance for multiracial identity. We'd also like to be able to essentially talk about each racial and ethnic endorsement people have. We would like to look at, for example, within the Asian category, we would like to be able to look at Filipino, Chinese, Japanese, Indian. Within Hispanic ethnicity, we'd like to be able to look at Cuban, at Mexican, at Puerto Rican. All of this is technically possible. It's just a matter of census being able to being willing to create data products that would enable that. I didn't mention this before, but we do some work to help predict preferred language and able to look at some of the specific differences that exist with language preference. For example, differences between Spanish preferring, the care for Spanish preferring and English preferring Hispanic hospital patients. And so let me just sort of stop there. There's some references here. If you're interested in looking at some of the things that I described, but let me stop at this point so that we can use the remaining time for discussion and my attempts to answer any questions you might have.
Thank you very much. That was really wonderful. We do have quite a number of questions, but hopefully we will get through most all of them. But if anyone has any additional questions, please use the Q&A function, as that is where I will be reading these from. Okay, so the first question here, does BISG include gender when using surnames to impute race ethnicity?
So in the basic BISG, we don't explicitly use gender. We tried this, and in the first name version, and we also don't directly use it in the first name version, but we tested whether adding gender helped in the first name version, and it doesn't. And the reason there is, although there are first names that don't strongly correlate with gender, the gender information that's present in most first names is so strong that adding gender to the information on first name, last name, and address didn't improve the prediction of race and ethnicity. Now, if our goal had been to predict gender, we wouldn't have everything that was there. But with the goal of predicting race and ethnicity, it turns out that it doesn't really add to your ability to predict once you have first name in there. The Medicare version also has first name in there, and so in that version, it's also the case that you actually don't improve your predictive performance by knowing gender. I mean, gender is widely available. Gender or sex is widely available in a lot of data sets, so you could add it, but if you have first name, it turns out not to improve your ability to predict race and ethnicity by that much.
Is age taken into account in these percentages?
So the Medicare version, so the basic versions don't incorporate age. The Medicare version does, and it's quite helpful because population distributions differ markedly by age. And so, for example, the Medicare data set, if you're older, if you're in the Medicare data set and you're 85, your chances of being, based on that information alone, your chances of being Asian or Pacific Islander are higher, your chances of being Hispanic are lower. And so that is a really useful predictor. So the kind of customized version does. I should also say, we're looking at things like specific customized versions for the marketplace, for Medicaid. And if you have a data set that has age information, then it's a really good idea to pull that in. We've kept the name and address versions very simple to be very general. But if you're going to be working in something that has age, you can definitely learn something from that, and incorporating that will help.
Wonderful. Does multiracial include Hispanic Latinx? And if not, how can you account for multiracial Hispanic Latinx groups?
So the way that it works right now is not the way that we would like it to be. So the categories that are currently used are ones where the multiracial category is limited to those who didn't indicate Hispanic or Latinx identity. And the only reason it's that way is that the surname lists that are out there are based on that particular configuration of categories. We see that as an undesirable thing. And so the data requests that we're trying to encourage the census to do with 2020 data, we're asking for them to provide information about surnames by Hispanic, Latinx identity, by each racial endorsement, and by finer grain racial endorsements. And if they're willing to do that, then it'll be a straightforward thing to create a next generation version of EISG that allows you to make those distinctions. We see that as critical, and hope that they'll provide the data that will allow us to modernize those categories.
Wonderful. How do you account for hyphenated surnames?
So the way we do that right now is if you have, so let's say that your surname were Garcia Rodriguez. If you just literally look at the surname list, and then if that's a common hyphenated surname, then you could use those probabilities directly. But the thing about hyphenated surnames is they're all possible combinations that are possible. And so what we do is we actually, if a hyphenated surname list doesn't make that 100 or more combinations, we break it into parts. We then look at each of those parts separately, and then we've developed an algorithm that combines that information, and that turns out to be really helpful. It's also the case that having a hyphenated surname itself tells you something about race, ethnicity, in addition to there being information in the individual parts. So we have developed code to do that. I should also say that we're in the process of trying to do something similar for hyphenated first names, less common, but also a way to kind of get at the underlying information that's there.
Great. So thank you for sharing the information about RAND and your website that will be sharing a lot of these information and tools. We dropped that into the chat for anyone who is interested. We did have a question specifically, will RAND be providing BIFSG probabilities in the CMS VRDC files? And is there any software being developed for these methods?
So the Medicare probabilities. So right now, we've sent to CMS probabilities for every current Medicare beneficiary, plus everyone who was a Medicare beneficiary, who's not a Medicare beneficiary now, but was at some time 2016 to 2021, and so that second group is mainly decedents for the last 5 years. And if you have access to the CCW, then you can get access to those probabilities via a data use agreement with CMS. And with respect to software, we have been for some time distributing the surname and address version, BISG. We now sort of think of the version that incorporates first name as being uniformly superior to that. We're in the process of cleaning up the code on that to make it sort of more shareable and user friendly. But our intention is to make that version of the code shareable soon as well.
Wonderful. How do these methods account for gentrification?
So the methods, so gentrification, I think, is something that is going to particularly affect the the residential address-based component of things. And so if you use, and one way to think about that is, if a neighborhood undergoes significant change in its racial and ethnic composition, then it's important to use residential address information that's similar in time to the time you're talking about. So let me give you an example. If you're using historic data and you're trying to look at, you're trying to estimate the race, if you're trying to estimate racial and ethnic differences, say in a 2008 data set, then you probably want to use a version of BISG that links to the racial and ethnic composition of different block groups in, say, the 2000 census. On the other hand, if you're doing this right now, you probably want something that's based on the 2020 census, so you'll get the most accurate performance if the part of the information that has to do with where you live is measured at the appropriate time, and that and you want that address information to also correspond closely in time. That said, we have looked a little bit at how much this matters. So, like, what if you how off are your estimates if you use information from 10 years ago rather than the current information with respect to residential address? And at least in national estimates, it often doesn't make too much of a difference. It makes less of a difference than we might have guessed. And part of that is because although some areas change a lot, a lot of areas change relatively slowly. And then the other thing is that in most of these methods, you're not relying too much on any one data source. And so in particular, like the Medicare version, which has lots and lots of data elements, if you use old address, you're off a little bit, but you're not off a lot. That said, the simpler methods, it'll matter more. And then also, if you're looking at a local area rather than something national, then the sensitivity to change over time is greater, and it becomes more and more important to have that data as close in time as possible.
Thank you. Do you have a sense of when completeness of self-reported data might be good enough to phase out or minimize the amount of records needing imputation? Is it 5 years, 10 years? What do you think it'll take?
I think it varies a lot with the setting. And I think some, so, I was talking to one hospital yesterday, and they say that if they're trying to look at quality of care for people who've had a procedure in the last year, they get self-reported race ethnicity for 95% of those patients. And so, that's you could argue that unless those 5% who don't report are really different in their race, ethnicity, and in their quality of care, that maybe they're right there already. On the other hand, the sort of, if you look at the medical group associated with this hospital and their whole set of patients seeing that group, they're looking at more like 20 or 30% self-report there. So they're pretty far. One thing I would emphasize is that if you integrate these two together, self-report where you have it, imputation where you don't, then you sort of get this smooth trending where essentially over time, the imputation becomes less and less. And it sort of, it eventually sort of evaporates, but it allows you to kind of make to do kind of consistent tracking from wherever you are now to the point where it's no longer needed.
Wonderful. So while this is clearly addressing racial and ethnic groups as related to health disparities, how does this apply to the queer and trans population?
So this isn't a tool that measures either sexual orientation or gender identity at all. I'll mention only a little bit in that regard. That's an area of interest, of research interest to me as well. There's one paper that I've been involved in that does some limited work in that area. So the National Health Interview Survey has a sexual orientation question that in addition to some more specific categories has a something else response option and a prefer not to say option. And there's some follow-up microdata which allowed people to elaborate on what they meant. And so, you know, we built a small model that allows and broadly you had kind of two categories of things happening. Some people, when they said, for example, something else, they meant that they had a particular sexual orientation response that they wanted to give, often other than heterosexual, but it wasn't sort of available in the first set of response options. And there was another set of respondents where, for example, they might have intended to endorse heterosexual, but they didn't understand that term. And it turns out that you can do a pretty good job of predicting who's who. Being older is a strong predictor of sort of not understanding the response options, for example. And so we have a paper that I could put this in the chat that talks about, you know, it's nothing like an overall ability to predict sexual orientation, but it's at least a sort of a simpler model to try to better, more specifically measure, match people's intended responses to sexual orientation questions when they're given sort of broader rather than more specific response options. But I'm not personally aware of a general approach for measuring sexual orientation and gender identity without direct self-report. But you know, there may be such work of which I'm unaware.
Next question, how do you account for religion and names associated with a religious tradition rather than their race or ethnicity?
So there isn't a direct attempt to predict religion in the model, and many names that have an association with a particular religious tradition are going to be informative with respect to race and ethnicity, and so all that really happens is if your name is that's sort of one element, and so let's say that you have a surname that's that was adopted or that's associated with your religious beliefs in one way or another, then what the algorithm does, it just looks at that surname and looks at the distribution of race and ethnicity of everybody who has that surname. In any individual person's case, their self-identified race and ethnicity may be common or uncommon among people who have that surname. If their identity is uncommon among people who have that surname, then what that'll usually mean is that there'll be some other elements of them, their address, their age, other things that might be more common with respect to another identity, and what that'll tend to do is create sort of more uncertainty in their probabilities. So one way to think about it is, if you look at the distribution of probabilities for a given person, at one extreme there's self-report. So probability of 1 of being this, 0 of being everything else. There are other people whose probabilities are sort of relatively distinct. So somebody might, based on all the information, have a 94% probability of identifying as white and 6% in other categories. Another person might have really spread out probabilities. So they might have a probability they might have probabilities that are not higher than, say, 40% in any one category. And in some ways, where there's information that's conflicting in some ways or surprising in some ways, that tends to push you into the spread out probabilities. And the effect is that your information is used more cautiously than somebody where the information is clearer. And this is sort of another case of why you don't want to use this to make decisions about any one person. But the approach essentially uses the information in a way that ensures accurate group level comparisons, and where greater weight is given where there's more certainty and more caution is used where there's less certainty.
Thank you. Are there any studies on comparing between allowing a machine to randomly assign versus doing it the way with all of these factors being taken into consideration? And if so, what are the outcomes of the study?
So I might or might not understand that question correctly, but I'll give it a shot. If you were to truly assign people's race and ethnicity randomly with not using any information, then you would get a C statistic of 0.5, which would correspond to chance. Whereas the C statistics you're getting when you use a lot of information are sort of more like 0.96, 0.99. And so if you were to truly do this randomly, then you would get answers that you get results that didn't correlate at all with actual self-reported race ethnicity. And then the estimates that you got would be invalid. That's one interpretation of the question. There's another interpretation of the question, which goes as follows. You can actually use these probabilities to generate random data sets. So for example, let's say that I have, let's be really simple. Let's say there are only 2 racial and ethnic categories and there are only 2 people. Person A has a 80% probability of being Black and a 20% probability of being white. Person B has a 50% chance of belonging in each group. A random data set would essentially, you could generate 10 random data sets, and in each data set, sometimes each person will be Black, sometimes each person will be white. And how often that happens will be dictated by those probabilities. That's essentially generating multiple imputation replicates using those probabilities. And then that allows you to use any kind of software program you like that counts on categories, not probabilities. And if you then combine that information using something like ProcMI ProcMI Analyze in SAS, then it gives you correct results, and that's actually a really good way to analyze the data. So you can actually use these probabilities to generate replicate data sets and essentially capture the information and the probabilities by doing so. So I'm hoping one of those 2 answers addresses the question as it was intended.
Thank you. Okay, I think we only really have time for one more question here. Could you address BISG and its uses for local health jurisdictions in estimating population health for survey non-response or undercoverage for underrepresented populations? How can local health jurisdictions use this with a limited statistical capability? Any recommendations?
So we've sort of tried to put these tools in the public domain, and we've tried we've had a variety of users over the years, and we typically pass code to people and pass some sort of examples of here's how you do this kind of thing that you might want to do, and sort of share articles and things, and as much as possible we try to talk people through how to do this sort of thing. There are different models for how this has happened. In a lot of cases, we've had sort of brief interactions with people, and they've been and they've sort of taken that and run with it. In some cases, we've developed sort of longer term collaborative interactions. So if this is something of interest to you, then encourage you to reach out to us, and we hope that we'd be able to help you with something that was useful to you.
Wonderful. Thank you so much. We are almost at the top of the hour, and I wanted to give a quick moment to our Center Director, Inez Ponce.
Hi, thank you so much, AJ and Dr. Marc Elliott. Thank you for presenting to us all of the decades worth of work that you've been doing on I want to use the word Herculean, but the task of dealing with missing data. I think that there's some questions that are specific here that we didn't get to, but we hope we can address. It's like some practical questions on how to use the probability of race in a regression model that we hope to address in our follow-up. But I'm also just thrilled that you continue to modernize and think about auxiliary data sources and thinking about the evolving demographic composition of the United States, as well as the intersectionalities that occur. So, and of course, place-based insights and the limitations of that. So I wanted to thank you again for taking time from your very demanding schedule to walk us through. We've tried to post as much as we could in chat, but for all of the community here that's joined us today, please know that this is a continuing seminar series. We've had several seminars so far. Please join us. We will have another one. I'm going to leave it to AJ to talk about that. And that Marc, if you would like some help and insights on some of your thinking, I hope that you'll lend an ear to this community of the National Network of Health Surveys to help. I
appreciate the opportunity to learn more, and I'm really really thrilled to learn more about this group, and hope there are ways to collaborate in future.
Yes, thank you. I mean, one quick thing was with your CAPS results, seems like, we in the California Health Interview Survey that the Center for Health Policy Research runs, we do put race, ethnicity further up, not last in our questions. Because I know you had mentioned that some of the utility is where people do want to self-report, but just don't get to it because it's at the end.
Yeah, I'd be interested in hearing more about that and learning how that plays out.
Yeah, the question ordering. Thank you. So, Dr. Scheitler.
So thank you very much to everyone who joined us today, and a big thanks to Dr. Elliott. We will have one more workshop planned. It's going to be on policy and legal implications of disaggregating data in your sources. We don't have a date yet, but all of you will get notification. Reach out to me anytime if you have any questions at all. We thank you all for your participation. Enjoy the rest of your Friday and have a great weekend.